Welcome. Today, we will demonstrate the surgical technique for ACL reconstruction with double extra-articular reinforcement. The authors have nothing to disclose. All cases should exhibit a positive Ligament test, indicating ACL injury. A positive pivot shift will indicate instability in internal rotation, necessitating anterolateral extra-articular reinforcement. The medial compartment should be tested, using the anterior drawer in external rotation test. The patient is positioned supine, with a pneumatic tourniquet applied to the lower limbs. Grafts are harvested from the semitendinosus and gracilis tendons of the injured limb, and from the peroneus longus in the posterolateral region of the fibula. Usually, the longer graft is the anterior half of the fibularis longus. This is folded to make it triple, measuring between 8 and 10 centimeters in length. Alongside it, we place the gracilis tendon in a single manner, with its remainder forming an extra-articular reinforcement. Similarly, but in reverse, we place the semitendinosus, whose end will be the other extra-articular reinforcement. All ends of the grafts will be prepared. Reconstruction is performed through anatomic positioning to create the femoral and tibial tunnels. The outside-in technique is used. The medial epicondyle is identified in the lateral view with the aid of radioscopy. At this point, a guide wire is passed through the femur, in the anterior direction, and a bone tunnel is constructed under radioscopic visualization. The distance halfway between the Gertie tubercle and the anterior eminence of the fibular head is found at approximately 1.5 centimeters from the articular surface. At this point, a guide wire is passed through the tibia in the anterior direction, and a bone tunnel is constructed under radioscopic visualization. The graft is pulled through the tibial tunnel and passed through the femoral tunnel. The two single portions of the graft remain out of the tibial and femoral tunnel until the ACL 10 cm portion occupies both tunnels. The graft is then pulled, and an interference screw is fixed to the femur and tibia. After tibial fixation, the remaining PL is passed through the subcutaneous, on the medial side. It is passed through the anterior oblique ligament femoral tunnel and fixed. The lateral portion of the single graft, which emerges from the lateral femoral tunnel, is passed subcutaneously in a closely articular manner and through the tibial tunnel of the awl. Both extra-articular ligaments are fixed under traction, neutral rotation, and full extension.